Okay, so moving on to cardiovascular. We're going to just do a little bit right now just to get started so we have the rest of the week to focus on the fun stuff. Okay, cardiovascular system, heart, blood vessels, and blood. That's all it really consists of. All the heart does is it pressurizes the blood, squirts it on its way, and repeats itself until you die. It's just a pump. On, off, on, off, on, off. That's all it does. The problems come into play is when you have alterations to how that heart pump functions. If you have clogged vessels, the heart's going to have to work a little bit differently to get through those clogged vessels. If you have high blood pressure, it's got to work through different ways to get through that. So all the alterations are messing up how well the heart works as a pump. The only thing that the cardiovascular system cares about is cardiac output, also known as Q. That is the homeostatic variable for the cardiovascular system. Cardiac output, that's all it cares about. Heart rate, stroke volume, blood pressure, those are all alterations to keep your cardiac output constant. That's the entire goal. It's the highway system that delivers all those trucks we talked about with the red blood cells and the hemoglobin. It provides the avenues for all that to go. We transport materials entering the body from the external environment. So when you eat food, we have to absorb that food into our cardiovascular system so it can go wherever it's got to go. Anything moving between cells within the body, and obviously getting rid of any waste products. Cardiovascular system will deliver it to the lungs to exhale, the liver so we can excrete it through the feces, or the kidneys so they can excrete it through the urine. We have to get rid of things too, and that's where we go. And exchange of materials between blood and the interstitial fluid occurs across our capillaries. And we'll go through why capillaries are the site for all that. This kind of goes over like the anatomy of the cardiovascular system. Make sure this is one schematic, but you'll get different ones. They're all the same. They all go in the same order. Make sure you understand how the blood travels through our system. Whenever we refer to the right side circulation, it's always pulmonary. Right side of the heart, right atrium, right ventricle pumps to the lungs. So we call that the pulmonary circulation, which is the right side. The left side is always the systemic circulation. It's going to the body. Left ventricle pumps blood to the entire body. Okay? So also the right side will be deoxygenated blood. It's coming back from the system. It's unloaded all of its O2, not all of it, but it's unloaded its O2 to the tissues. And when it comes back, it's going to be a little bit hypoxic to the lungs. We need to go back to the lungs and load up on oxygen again. So therefore, all the oxygenated blood goes to the entire body. So heart failure. All heart failure is inability of the heart to pump effectively. It's just a pump. It's not going to work as well. This is where I gave you that example in the beginning of the class with the light bulb not turning on, knowing which way it's going. If your heart is failing, we have to know what side is it failing. Is it left sided circulation or is it right side circulation? Where's the problem happening? It could be the whole heart, or it could be just one part versus the other. Knowing anatomy, which way everything goes, if my left side of the heart, the left ventricle is not pumping well, so I can't move blood forward, where's blood going to get backed up to? The lungs. So I can't pump it out through the heart. The left ventricle pumps the blood to the body. It receives it from the lungs. If the left ventricle can't pump the blood, it's going to back up into the left atrium. And then it's going to back up into the pulmonary vein. Then it's going to back up into the lungs. And guess what happens when all that blood fills up in your lungs? You get problems breathing. That's why people with left-sided heart failure have breathing issues. On the right side, where is the right side pumping the blood to? The lungs. If the right ventricle is failing, Where's the blood going to back up to? What's the immediate system chamber right before it? Right atrium. Then it's going to go into your vena cavas. Then all the blood that you're trying to get up from the legs can't go anymore because we're backed up. The right ventricle. What do they get? Swelling in the legs because all the blood backed up. The right side of the heart can't pump it effectively. You back up. That's why knowing the anatomy, what's the pathway it's going to take, will tell you what symptoms you're going to have. So again, organization, our pulmonary and systemic circulations are in series, which means you have the pulmonary circulation going into the heart, going into the left side, and then the whole thing just repeats, or the body, or systemic, actually, I'll put systemic. That's in series. They go 1 to 1 to 1. There's no mixing. Pulmonary system has lower pressures. What is a blood pressure? What's a normal blood pressure? 120 over 80. That is the left side pressure. That's the pressure generated by the left ventricle. Very high pressures. The pulmonary side, it's a lot lower, like 40 over 20, 40 over 5. Very, very, very low pressures on the pulmonary side. Systemic circulation is in parallel, meaning once the heart beats, some of the blood can go to the brain. Some will split off and they'll go to muscles. Some will split off and go to the kidneys. But then they all group up together to go back into the IVC and then back up to the body. So that's parallel. Whereas looking at pulmonary versus systemic circulation, it's in series, but within the systemic circulation, it's in parallel. That will become very important when we get to hemodynamics because our pressure is divided amongst all those parallel circuits. It's a way for us to alleviate pressure in the system. Okay, so hemodynamics. So pressure. We measure pressure in millimeters of mercury. That's why your blood pressure that you register on the machine is in millimeters of mercury. That's the pressure unit that we use. Flow is a difference pressure between 2 points. Flow will always go from high to low pressure. And it's these pressure changes in the cardiovascular system that allows our blood to flow effortlessly. Our entire cardiovascular system is closed, so no matter whatever goes in has to go out. And because it's all a closed system, the difference between the aorta and the large central veins, your IVC, is what drives the flow through the entire cardiovascular system. For example, the aortic pressure, let's say, is about 120. IVC, we also call it right atrial pressure, is about 5. That difference allows for flow to go from the aorta through the entire body back up to the IVC. As that IVC pressure starts to rise, let's say now we're still 120, but say we're volume overloaded, and now our IVC pressure, let's say it's 15 now. What do you think is going to happen to the flow through the system? Slow down or speed up? Slow down, because the gradient got smaller. That's what flow is referring to. Blood by itself, it's a liquid. It can't compress. So when the ventricles squeeze, it starts to pressurize the blood, causing potential for flow. I told you there'd be physics involved. Okay, there's a lot of physics in this whole system. So all we're doing when your heart squeezes, we're pressurizing the blood. So when that blood gets released, it flies out. It's like you have a hose and you pinch off the end, so no flow of the water can happen. Then you release it and it just flows out. Same thing with this. The amount of flow between 2 points also depends on resistance. What is resisting flow? And that's what's very important as we get to pressure. Ohm's law, the flow is proportional to the pressure gradient. The bigger the gradient, which we discussed before, remember 120 to 5, is proportional to flow, so pressure, and inversely proportional to resistance. So, the bigger the pressure gradient, the better the flow. If you increase the resistance to blood flow, your cardiac output goes down. So resistance, the more resistance I give you, the harder it is to flow. The bigger the difference between the 2 points, the easier it is for flow to occur. So we're going to be talking about pressure gradients. How does that affect cardiac output? What's going to happen with pressure gradients? And how we alter resistance to flow. Here is the formula for resistance. There are 3 things we need to worry about when it comes to resistance. Length of the tube. How thick the blood is, which is kind of a negligent factor in the body. The only real times that the viscosity can really change, and it's very rare that it happens, is when you have that polycythemia. What's that? Too many red blood cells. The more red blood cells you're adding, the thicker your blood can get, so viscosity can go up. Another one is in severe dehydration. All the solvent is coming out of the blood, so it gets thicker. If you ever reduce sauces with heat, if you're cooking, you want to boil off the water, so you're left with more of the stuff. Same thing with viscosity, but it's very rare that it happens much. So we don't really worry about viscosity. Radius of the tube is the big one. What's the radius? And if you look at the formula, where is the radius? On the numerator or the denominator? Denominator. Also, look at that equation. The resistance is to the power of 4. It's a 4-fold change with changes in resistance. Resistance is the big thing that we can alter. Okay, which nervous system, autonomic nervous system, which parasympathetic or sympathetic, will cause constriction? Sympathetic. Well, parasympathetic will causes some tone to happen, more is relaxation. But we want to constrict our vessels, we need alpha agonists to do that. So we can alter our vessel, we can relax our vessels to make them bigger, to reduce the pressure. So pi r4, so resistance is the bigger, radius is the biggest factor. Radius of your vessel. And we know the radius is all under smooth muscle control, and we know we can alter that with drugs. So resistance is, the biggest factor of resistance is the radius. So if the radius of the vessel decreases, what happens to the pressure going through that area? Increases pressure. Or you can say also increases resistance. If we're increasing the resistance, we're increasing the pressure. The length of the tube also matters, but it mainly matters with IVs. So again, radius is the dominant variable. If you double the vessel radius, it increases the flow 16-fold. So that's why increasing the radius of the vessel a little bit will produce big changes in resistance and pressure. And again, through vasoconstriction, vasodilation, we can alter the radius, alter the resistance, alter the flow. So IV catheters. A catheter with a large radius but a short length reduces the resistance to flow. Large bore peripheral IV is better than a long central line for fast infusion of products. So if you're ever infusing fluids, it's faster to go through an IV line because you have less resistance to flow because the vessel is, the radius is bigger and the length of that IV tubing, that needle that's actually in your arm is smaller. That provides greater flow through it. A central line goes to the neck and it's going to come all the way down. It's got a long tube. That's going to impede the flow with having a very, very long tube. Very good for medication administration through a central line because it doesn't matter the speed at which you get the medication. But fluids, those things do matter. Another definition word you got to know is compliance. Compliance is the distensibility of a structure. Okay? For example, compliance. If you're catching a baseball and you have a glove and your glove is pretty well, like it's loosened up, when you catch the ball, the compliance of the glove is going to absorb the impact of the ball. So your hand doesn't go flying backwards. If I caught a ball like this, my compliance is good. But if it hits my hand and my glove comes flying back, that means my compliance is bad. I wasn't able to absorb the impact of the ball. Same thing with hockey. If you have a hard stick and you're waiting for a pass to come in, the puck's going to bounce off the stick. But if you have good compliance and you accept the puck, then it just goes right in and you're okay. Another example is stiff structures, so like a stiff garden hose that has very little compliance. You can't bend it. It's going to break if it gets very brittle when they get very stiff. So we don't like non-compliant hearts. We want very good compliance, and this is where it comes into play. Changes in compliance of cardiac muscle affect the ability of the heart to fill with blood. That's the compliance. Your heart should be like a water balloon. It should accept all that blood. The chamber size gets bigger. If you had a very stiff water balloon that would not expand, when you put water in there, because it can't expand, the pressure builds up and it's going to squirt out the top. We want a compliant vessel, chamber. So compliance, this is the definition. The ability of the heart to hold a volume of blood with low pressure buildup. We want to hold a large volume of fluid, blood in this case, with minimal changes in pressure. Because we are a cardiovascular system, the system is closed. We are dealing with fluids. If you increase the pressure of the volume of the fluid, you increase the pressure. They go together. So, compliance, changes in volume over changes in pressure. Okay, so this is how I want you to know this one. We're going to be doing these graphs a lot come later this week. We have pressure and we have volume on the bottom. So obviously, as we go up the line, pressures get heavier or greater, and volume as we go across the x-axis, volume goes up. So we're talking about compliance. Compliance is always filling of blood. Okay, compliance is one of those words you got to know the definition of because we're going to talk about compliance a lot. So knowing what the definition is very important. So compliance, changes in volume, changes in pressure. We're going to talk about the blood in the heart, and our heart is going to fill with blood. So we're filling. Heart's going to get bigger, we're going to fill with volume of blood. So let's do it in red. So we have this line here. Let's draw these lines down. And we have a certain volume, right? We have a change in volume. Let's say that the change in volume for this example, let's just say it's 20 units or whatever it is. It doesn't matter. We're just using it for math, just to show you guys the principle. Now, let's look at the pressure on the y-axis. And we compare this increase. We have this line, and we have this line. Everyone get that part? That change in pressure is very minimal compared to that big change in volume, right? So we're able to hold a lot of volume with very minimal changes in pressure. And let's just say for math, that this change in pressure is 5. Compliance is volume over pressure. We divide it out, we get a compliance of 4. Everyone good there? Okay, we want high number for compliance. Higher the better. Now, let's say our heart became very stiff. Let me just change the color here. Okay, so our heart became stiff. We are losing compliance, which means this same volume of blood that we're adding to the heart is going to cause bigger changes in pressures. So instead of being the line like that, the line may be like this. I'll put it in green cell. That could be our new compliance line. Now look, still the same, still 20, but let's look at the green difference now. Let's say this change in pressure, we have a bigger swing. Let's say it's 10 now. That change in pressure. What happened to our compliance here? Where is it now? 2. It's gone down. So we want our compliance to be high. It's the ability to have large volumes of blood with minimal changes in pressure. That's compliance. Okay? So as you're studying, again, know what compliance is. Ability to hold on a large amount of blood with minimal changes in pressure. Because as your compliance goes down, guess what happens to your blood pressure? It's going to go up because the heart is getting stiffer. So that's the compliance one. Don't worry about this for now. We already kind of went over that. And, okay. So here's our heart. Have you guys started this? We haven't for anatomy yet, so the next section you will. Know also, when diastole is filling of the heart, systole is squeezing. So systole has a smaller size than diastole. A diastolic heart is a filling heart. So whenever you see the word or hear the word diastole, think it's filling. Systole is pumping. So diastole, the heart's filling with blood. It's got more contents. The heart's going to get bigger. That's why there's a dashed line for diastole. Systole, the heart squeezes and squirts out the contents of the blood. Cardiac muscle, again, is striated, has intracellular sarcomeres like the skeletal muscle, so it's in striated, so we have all those cross bridges, the actin and the myosin occurring. That's still going to be here, same as before in skeletal muscle. Different thing here is that cardiac cells have these transverse tubules, or T-tubules, that extend into the cell. There is a sarcoplasmic reticulum with every T-tubule. What is the purpose of the sarcoplasmic reticulum as far as for this purpose? Calcium storage. Remember, all that internal calcium is in the sarcoplasmic reticulum. Myocytes also have these gap junctions, and that means that when one heart cell will depolarize, the entire heart will depolarize because of the gap junctions. So all the cells go. That's that all or nothing principle of the heart, that once one goes, then they all go. Excitation, contraction, coupling. So we talked about this a little bit with neuro. We have to excite the cell first, then you could have a contraction. So cardiac muscle can contract without nervous stimulation. If you took out the heart by itself and it had no innervation at all, you cut all the nerves to the heart will have an intrinsic rate of about 100. It goes down to 80 because what system is in control of our body the majority of the time? Parasympathetic, which is rest and digest. So because that system is mainly in charge, our heart rate goes down to 80, normally resting. But if you took everything away, it would just be on its own at 100 beats per minute. Same thing, pacemaker cells generate action potentials. What generates the action potential or the depolarization movement of what ion? Sodium, okay, causes that same depolarization. That depolarization goes along the T tubules. And it's this location where we have our voltage-gated calcium channels. And calcium comes into the cell from the outside. However, in cardiac muscle, they have a very special thing. It's called calcium-induced calcium release. As the calcium is coming in from the outside, it causes the SR to dump calcium into the cell as well. Calcium-induced, the calcium coming in from the outside, stimulates the SR to release calcium into the cell. Calcium-induced calcium release, same procedure happens. What does this calcium bind to in the muscle? Troponin C. Remember, that's where calcium goes. And the same exact thing happens. Everything else is the same. How do we relax the heart? We have to get rid of that internal calcium. Remember, as long as calcium and ATP are there, you're still going to have that cross-bridge cycling. But the heart is on a cycle. We have to have it squeeze, we have to have it relax. It's got to squeeze, it's got to relax. So we can't just have all that calcium sitting there all the time. We have to get rid of it. We have two things. We have a sodium calcium exchanger, and that's going to get it out of the cell. We also have our calcium ATPase pump that puts calcium back into the SR. So two pumps, well, one's the exchanger, but still two ways to get rid of all that extra intracellular calcium. We have the sodium calcium exchanger, which gets it out of the cell, and that calcium ATPase pump, which pumps it back into the SR. And that's how you get rid of calcium in the heart. Let's see where we're at here. Okay, we're almost done. So here is our sarcolemma, T-tubule, whatever you want to call it. Here is the extracellular space, and here is the intracellular space, ECF and ICF. First thing that's going to happen, what has to happen first? Action potential, right? Okay, there's our action potential happening. It's going across the nerve, right, across that muscle cell. Okay, as it goes across, this is the actual T-tubule. This whole structure right here, that whole thing is a T-tubule. As the active potential comes down into the T-tubules, what is here? Here's our active potential. Comes down. What type of voltage-gated channels are at the very end? Calcium. Okay, so these are our calcium molecules, and they go right through and go right inside the cell. Now, these are the SRs, sarcoplasmic reticulum. Remember, there's one for each T-tubule. What's inside the SRs? Calcium. Okay? Calcium's got to get out. So calcium comes out. And this whole process is called what? When the calcium comes in, sparks the calcium to leave the SR. Calcium induced, calcium release. Okay? So calcium now will bind to troponin C, and we get cross bridge. Muscle contracts the same thing we did in the first unit. Nothing changes. Calcium, ATP are both required. So we have a calcium-induced calcium release. So we have calcium coming into the cell from two sources, extracellular fluid and the SR. Now we have to get rid of the calcium. So how do we get rid of the calcium? We have a sodium-calcium exchanger, which is going to get calcium out and bring sodium in. We also have a calcium ATPase pump, which is going to bring calcium back into the SR. Okay, so the active potential comes down, hits the T-tubule. In the T-tubule is where our calcium-gated channels are located. Calcium comes in from the outside, causes a spark of calcium to be released from the sarcoplasmic reticulum, calcium-induced calcium release. All that calcium will bind to the troponin C, cause cross-bridge cycling. We have to get rid of the calcium, sodium-calcium exchanger, and the calcium ATPase pump.
Does the sodium get pumped back out after?
How?
With the sodium potassium?
Yep. So this is just a review, just about different things. This I want you to bring up though, and then we're done. So any drug that can increase intracellular calcium will cause an increase in myocardial contractility. The more calcium you have, the stronger the contraction is going to be. So we can give drugs, for example, one of them is called digitalis, increases myocardial contraction, by bringing in greater calcium stores. How does it do it? So digitalis blocks the sodium-potassium ATPase pump. If you block the pump, you're going to get an increase in intracellular sodium because the pump is there to get it back out again. Pump's not working, sodium starts to build up inside the cell. Because it's starting to build up with intracellular sodium, it's going to alter the driving force for your sodium-calcium exchanger. So that exchanger is not going to work. What's the purpose of that exchanger? Get calcium out of the cell. But it's not working. So where's calcium going to stay? Inside the cell. We get increased intracellular calcium, more calcium to be stored in the SR, and then the next excitation, more calcium comes out, a greater contraction. It's going to happen every single time once you're at therapeutic levels for digoxin. But this, you don't have to memorize this thing. But what is this showing you? It's showing you a couple of things. One, how important calcium is to contraction of our heart. The greater the calcium, the greater the contraction of our heart. That's why we give calcium channel blockers to bring your blood pressure down. We don't want you to have that much calcium, so we give you medicine to do that. Another way to do it is by altering your sodium-potassium ATPase pump. By shutting that down, sodium builds up inside the cell. That's going to alter that sodium-calcium exchanger. Calcium is going to stay inside the cell more calcium in the cell, the greater the contraction. That's how digitalis produces a greater contraction, by blocking that sodium-potassium pump. So if you understand how that blocking of that pump works, it makes everything else make more sense. That's pretty much all we had for right now for this one. Remember, with this first lecture is just definitions. Tomorrow we go through all this fun stuff. So we're going to go through a lot more active potentials tomorrow, how EKGs are formed and whatnot. So I'll see you guys tomorrow.